We can go ahead and get started for today, and as others join, they can ask their questions. What we're going to be doing is we have our MCT2D lead pharmacist, Dr. Heidi Diaz, here with us today, who is going to be starting with just a brief introduction to herself and her career and her role in MCT2D. And we've also received some questions that were submitted ahead of time via the registration process. Heidi will start with those and go through them, and then we'll be happy to take any questions that you have in about you today. So I'll hand it over to Heidi.
Jackie. So hello, everybody. Thank you so much for joining me today. And I am going to share my screen and get started here. So give me 1 second. Do this. All right. Jackie or anybody on the call, are you able to see my slides?
Yes, ma'am.
All right, thank you. Okay, so I did want to just start off with giving you a brief trip down memory lane for my background. I did take an untraditional path to becoming an ambulatory care pharmacist, but I think that also allows me to really understand the ins and outs of different parts of pharmacy, and then also bring that to the team of physicians that I work alongside. And also it helps with patient advocacy and costs and insurance companies and all of that as well. So I got my doctorate from the University of Michigan. I then went on to do a community practice residency at the University of Washington in Seattle. And after that, I was then hired on by a partnership between Bartell Drugs and the University of Washington to start to establish clinical services at Bartell's, which is a local chain that was in the Pacific Northwest, and then come back and teach in the classroom at the University of Washington. About 3 years after that, U of M came knocking on my door again and wanted to know if I wanted to come back and be the first community faculty member at the College of Pharmacy. And at that point, I was very happy with my life in Seattle. My entire family's here in Ann Arbor, and they even used my dad as a plea to, why don't you come home? But I heard about the position. I thought it was a great opportunity, and to teach at my alma mater was a pretty big, important move for me. So I came back, and as I was establishing clinical services for a local chain, I also got really involved and interested in diabetes. And so at that point, I reached out to my mentor, Hammy Cho, and wanted to grow in the area of diabetes. And so she offered me an opportunity to partner with one of the internal medicine clinics and start to build relationships there. And out of that came an opportunity to transition full-time to becoming an ambulatory care pharmacist. So I did that in 2010. At that point, I was running Taubman Internal Medicine and then also Briarwood Family Medicine. And within 2 years, I had 4 clinics that I was running under my belt. And so that then took me over the last several years up until last year when I interviewed for this position to be the lead pharmacist for MCT2D. And I think it was a moment in my career that I felt like all the things that I've been working towards had come together. My passion for patient care, my passion for diabetes, my passion for teaching. I think there's a level of sharing what I know and working with others to all grow together. So that's what intrigued me the most about this position. I'm sure most of you know this, but I thought it might just be nice to kind of talk about a day in my life. And so I am able to prescribe under a collaborative practice agreement. So that gives me the opportunity to prescribe medications, medical devices for diabetes, hypertension, hyperlipidemia. I can send referrals that are related to those chronic diseases along with labs. The physicians that I work with send referrals to me, and patients are, well, to the referral pool, I should say, and then patients are scheduled with me. Prior to COVID, I'd say I was 50-50 between patients coming in and doing them over the phone During COVID and now, I'm at 3 half days a week. I have 1 half day in person and the rest are virtual. And I would say on those in-person visits, maybe 2 to 3 patients coming in. So I have seen a huge uptake in my video visits. I'm sure as we all have. And I'm thankful for that because I think it's given me an opportunity to stay connected on that personal level with my patients. In terms of the benefits or where I see are the benefits of having a pharmacist in the clinic or me just being able to work with the team of physicians that I do, I think it's a great team-based care. I'm able to spend anywhere from 15 minutes, 30 minutes, 45 minutes on one single disease state. I think it allows me to show my expertise in the area of diabetes and really help find the most evidence-based solution for a patient. And then, as I mentioned, my prior background, I think I'm pretty savvy at navigating insurance coverage and finding different solutions and knowing kind of how to work the channels. A typical day, if I could say typical, I think one of the things that I love most about what I do is no day is ever the same, but I approach it in the same way. So every visit that I have for diabetes, I get a good idea of what the patient, what their diet looks like. Do they understand how many carbs they're eating? Do they even know what carbs are? And then trying to get a baseline idea in terms of movement. And I think one of the things that my patients usually respond to me on is, I try not to use the word exercise, I say movement, because there's a huge spectrum, and we work on making goals around that. From there, we dive into medications. I think one of my roles, as you all know, as a pharmacist would be making sure doses are correct, administration, making sure I address any administration challenges, especially when I'm dealing with so many injectables. Affordability of these medications. And so, a lot of the MCT2D tools that have been created are different resources that I had and was using. And then just staying up to date with all the guidelines and new medications and trials that are coming out and how that impacts our patients. From there, the glycemic assessment. So I do a lot of CGMs. And then just review of blood sugar readings. I think a lot of my physicians are always like, how do you get the readings out of them? And I said, they know what to expect when they come and they start working with me. So I will ask for 2 weeks of blood sugars on every single visit. And we spend time going through each one and understanding what things might have impacted. Again, I have the time to do that. Many of you do not. Helping with health maintenance. And then of course, coming up with a plan, deciding what to do. Are we going to titrate something? Are we going to stop and add something new? Or are we just going to add something new? Or maybe we're not going to do anything and we're going to identify some lifestyle stuff to work on and hold off until maybe the next A1C to determine next steps. So I think there's a lot of words here, but I love what I do. I love the fact that I get to help patients live a healthier life. And I think some of my strong suit lies in motivational interviewing and helping patients set tiny little goals to meet the bigger ones. And I think one of the most powerful things is getting patients. Often a lot of the patients that are referred to me have had diabetes for a really long time, and their doc's like, here, you take this patient on, I can't get their A1C to goal, see what you can do. And I always come back to the foundation. I come back to diet and exercise and I make my assessment and we start there. Now, do I add meds on? Yeah, but I think I'm really good at championing my patients. And I think that's where this team comes in. We all work together to help our patients. I think the rest you can kind of read here. The other thing I really do enjoy is I take pharmacy students, but I also take medical students. And I think it's fun to have everybody working together and to see what the pharmacist offers to the visits they're coming and seeing with the physicians they're rotating with. And they always come in and say, oh, I just saw one of your patients, and they mentioned what you were doing. So it's a lot of fun to just keep getting that team model going. And then finally, with all the work we're doing here, just advocating across the state for patients with type 2 diabetes, I literally have found everything I could have ever wanted, and I'm so excited for what's ahead. So with that, we'll get to our first question. So all things being equal, copays, insurance, what is preferred? SGLT2s, age in GLPs based on the data. So I love this question, but I think when we have to dive in, and I'm about to in these slides, I need to know more. I got to know more about that patient. I need to know what their A1C is. I need to know what their other comorbidities are. Insurance comes into play at some point, but really understanding who the patient is, where they're at, what meds they've are currently on, what they've tried before, is going to really help me see the big picture and what route I might want to go. And again, knowing where they're at with that foundation, I can't say that enough. I really do spend a lot of time with each and every one of my referrals that I get, is understanding the foundation, and that always kind of layers into the steps that we take together. So you all probably are well aware of this. This is just a snippet from the ADA Standards of Medical Care, the algorithm that's in section 9. And in 2018, we saw for the first time going away from, metformin, lifestyle, and then all the different classes and you pick, to this guided, does patient have one of these comorbidities, ASCVD, high risk for ASCVD, CKD, and heart failure, and then really having the SGLT2s and the GLPs there. And then we'll come back to this. So I really apologize for this slide, but I wanted to try to put kind of what goes through my brain on one slide. So I'm going to try to walk through it. So first thing comes to mind is, how much A1C lowering do we need? When comparing the two classes, when I think between an SGLT2 and a GLP, if I need anything more than 1% lowering of A1C, I'm going to go GLPs, because that's where you're going to get your highest A1C lowering between the two classes. From there, I go back to the patient. If I have a patient who has never dealt with an injectable before, I'm going to start thinking weekly medications. If I have a patient that I can even open the conversation with this drug class and they start talking that they don't like needles, one of the things I do use is whether they're testing their blood sugar. I find that a lot of my patients, when I ask that question, they're like, yeah, I have no problem poking my finger. I just don't want to inject myself. And I'm like, you realize here's all your nerve endings, and that needle that you're poking is not much bigger than the pen needles that are in these devices. And they're shocked. I really honestly think sometimes patients think that it's like an intramuscular injection that they're getting. And so I bring out a little pen needle and can show them. If we're on a video visit, I can flash a little graphic that I have on the screen, or show them. I have demo pen needles here in my office. So I go back then, getting to the point of this, are they really afraid of needles? Then an auto injector might come into play. From there, you start then broadening out. So we got to think about outcomes other than glycemic control. So I start thinking about, do they need ASCVD protection? If they do, we're down to 3. How are their kidneys? I avoid exenatide by Durion if I have patients with renal function below 50 usually, because the cutoff is 45. Then, of course, weight. We got to think about why, there's patients excited about these medications, surprisingly. And so we start thinking about that factor. How much weight do they need to lose? Is that one of their motivating factors? Going back to weight and appetite, I sometimes use liraglutide in my patients that are having more kind of intense appetite that they might need like a daily kind of reminder for the appetite suppression. Now, the appetite suppression should be there across the board, whether daily or weekly, but I have seen a difference. So that's something else that goes into my differential in terms of picking a medication. So your two, I think, highest A1C lowering agents, dulaglutide, max dose, semaglutide, max dose. With the addition recently of semaglutide 2 milligram, I think there's not as much level playing field. Semaglutides come ahead, higher A1C lowering, higher weight loss potential, but again, it's at max dose. And so then getting patients to be able to tolerate that max dose is something with any GLP that we have to work together on. I think I took out from this slide, I usually have titration schedules. And, semaglutide, I pretty much stick to the 4 weeks. Sometimes I go longer in my patients. If they're not tolerating it, I will increase across the board here the timing between dose titrations, because if we can get them over the hurdle of that first dose, we're going to be able to keep them on that drug and hopefully get them to these more optimized dosing. We flip over to SGLT2s, like I said, typically when I'm thinking of A1C lowering, if that's my guiding principle between the two drug classes, it's somewhere in the range of the 0.5 to 0.1. I found this article, it came out of Cleveland Clinic in 2021 for this table, and I think it really highlights the impact on glucose, with EMPA and CANA really being the glucose heavy SGLT2s. And then I didn't want to forget talking about renal thresholds and why we have that. So recall that, empagliflozin, for instance, if you look at package insert, it goes down to 20 GFR. If you're trying to get any glycemic benefit, though, your cutoff is 30. I think the other thing that I always like to talk about when I'm thinking of this is I have a patient who, let's say, is on metformin, and I'm thinking between one of these two drug classes. They might have, let's say, a BMI of 29 or 30. A1C though of 9, or let's say 10%, 10.1. Without a doubt, I would go GLP, and it's not only for the A1C lowering potential, but the thing you got to keep in mind with SGLT2s is when you get in A1Cs above 9%, the incidence of the why am I blanking? Genital urinary side effects increase. And so I've had the discussion with my endocrinology colleagues that they practice in much the same way, that if you have A1Cs higher than 9, you're going to increase the incidence of those side effects. So we usually wait. You can add other medications until you get the patient down below that threshold, and then eventually switch over to oral, or add on in many cases to get patients to goal. So just something I wanted to bring up there. The other thing with SGLT2s is recognizing that tolerance to blood pressure, side effects, labs really come into factor of when you titrate with this drug. So wanted to bring that up. Then, of course, thinking through which of these drugs within the class have the outcome trials to boot and back their indications. And so I have ertugliflozin on the screen. I have never ever prescribed it. It was non-inferior to placebo in both the CV trials and the renal trials. So I don't use it. I have 3 other ones to pick from, and I'm super excited for it. We just are getting the results with the EMPA kidney. So I think we have 3 great choices. So trying to put it all together, get back. I think this is how I think across the whole board, but you're really seeing that we're down here in terms of our classes. And so then picking between the 2 comes down to those factors that I went into. And if there's still questions about this, once we get through a couple more questions that were submitted, I'm happy to come back and talk through some specific questions or cases that you might have. But tried to kind of walk through my approach. I gave this slide, I wanted to just share it with you. I gave this to my physicians. I talked through some of this. Reminder too with GLPs to avoid dual therapy with DPP4s. That being said, if I have a patient that I'm switching from a DPP4 to a GLP and they have 20, 30 tablets left, especially on many of them that have a subtherapeutic starting dose, I will overlap then just so I don't waste expensive drug. But in general, there have been no studies to promote, to say that there's any increased efficacy with dual therapy. The other factor, and I'm glad I'm looking at here, between deciding between the 2, SGLT2s versus GLP, if you have a patient that is, saying that they're snacking all the time, they just have an appetite that's there, that really should direct you to GLP, because there is no appetite suppression with SGLT2s. And so that's another indicator when I'm going through their diet, talking about their meals, asking about snacks, that'll kind of cue me into which way I might want to go. With SGLT2s, certainly hydration is important. Talking about sick day. So if they become sick, and to the point that they're not taking anything in orally, they need to be told to stop their SGLT2. The other factor that goes back to that foundation and that diet is asking our patients, when you're thinking about prescribing an SGLT2, what's their diet look like? What kind of lifestyle are they, eating pattern are they using, just to get at, are they doing a low carb? Because if we don't ask, we don't know. And I think we've all heard plenty of times that we're not gonna combine a low carb diet with SGLT2s. But again, if we don't ask, we don't know. So next question. How well do PharmDs understand the cost to the network, for example, risk versus the cost to the patient? It seems like the focus is on making the cost cheaper out of pocket and removing prior authorizations. So I think this is a very interesting question, and I think the short answer is I don't know as a PharmD, and I don't know how many of my fellow pharmacists know the answer to this question. I would say in the role that I'm in now, I have come to just begin to understand risk contracting and understanding the complexity that I've just barely scratched the surface, but understanding there's differences for each payer and PO and practice. I think what we as MCT2D hope is to work together to find ways to rationally construct these risk contracts and work with everybody and payers to, find value in reducing the cost of, well, let me say, by having patients on these medications, GLPs, SGLT2s, we know there's data. If any of you were at our our statewide meeting on Friday, you saw Allison's presentation in terms of how cost can be reduced long-term via decreased hospitalizations, decreased ER visits that offset that initial cost of the drug. And I think in time, we're going to get more and more of that data to support long-term cost reduction. And I think once the payers start to see that, we will get to a better place with these incentives and whatnot. But beyond that, I don't know. This is not my area of expertise. I practice and try to be as most patient-centered and evidence-based in terms of my practice. All right, so in patients with concomitant diabetes and obesity, should we be picking one GLP over another? I think I'm going to flip back real quick to slide and bring your attention to that bottom row in terms of weight loss. I think you can certainly say if picking, we have to consider the patient. And so if we have a patient who's obese and injection naive and maybe has any hesitancy, I'm probably going to move to the weeklies. Within the weeklies, I would definitely then go to the right side of the screen, dulaglutide, semaglutide. I think the other thing is if insurance pays the same for Trulicity versus Ozempic, you can see the weight loss difference between the two. So does that factor in? Absolutely. But I think I consider all those patient focused. They have to attach a needle. If I have some with Ozempic, if I have somebody that's just not sure, but I can get them to try and they don't want to see the needle, then in that particular patient, in reference to this question, I would go to Trulicity. And then if they do well and they get, get it under their belts about how to do this and we're not seeing the benefits, I don't think there's any problem with eventually switching. So again, I kind of let my conversation with the patient guide my decisions and which of these agents I'm going to pick. Sorry about this. Okay. Does the patient need to have a high A1C to qualify for an SGLT2? Patient high risk for CVA-MI, A1C 7 on insulin only. I guess the qualify, I'm not quite sure in terms of, are you saying that will their insurance pay for it? I think from what I've seen in my own practice, essentially if I have a patient on metformin and I'm adding something else, there isn't a qualification for even, having these other comorbidities of heart failure or CKD. I've never been asked like their ASCVD risk. I think if you can get, if it's covered, then I would have no problem with a patient with an A1C of 7 thinking about adding on an SGLT2 if they need cardiovascular protection, because they're not getting any cardiovascular protection from their insulin. And then depending on that dose of insulin and a lot of other things, could we, this is what would be going through my head, could we decrease their dose or get them off insulin? But with the patient kind of info that I'm giving on this screen, I think that would be the best way I could answer this question. And then the last question, if a patient's on multiple medications, how do you know which one to change first? I think I go with the approach of, if patients on a sulfonylurea, if patients on, one thing that I guess getting to insulin, if they're on basal insulin only, and their BMI is elevated, and they're wanting to lose weight, and we're working on some things with diet, and maybe we have graduated from walking down the driveway to walking around the block. So we're doing some good lifestyle goals, but they're interested in losing weight. I think I start looking at what medications they could be on that could be leading and contributing to the trouble losing weight. If on basal only insulin, one thing that I teach all of my learners, whether it's pharmacy or the med students, is to look at their basal dose. And the question that they have to be prepared for with every patient that they present to me is patient's basal insulin maxed out. And so hopefully you all know what I'm saying here, but just in case, you can take a patient's weight in kilos and cut it in half. And that is approximately their maximum basal insulin. And so when I first started at my clinic, I was getting referred patients with 80, 100, 120 units of basal insulin. And, you know, there's at a certain point that you can, as we have heard the term, over basalization for patients. And so I think that's one of the things that I look at. If I'm seeing that a patient is on nearing that maximum basal dose, then what other things could I add to offset this? But then still going back to the foundation, finding out, you know, is there anything in their diet that they can work on? And you'd be surprised in the patients that I talk to that I then send off to Rena, who happens to be my dietitian at my clinic. You know, once I can identify where we need to work, then we can work on that and then focus on some of the medications and kind of peeling things off. If I didn't answer that question, please chime in and ask me more. So with that, I'm gonna stop sharing my screen because those are all the submitted questions. And I am happy to hear from you.
If you'd like, you can put questions in the chat as well.
Oh, I didn't look to see if there's any. Nope. If any of the people that are submitting these questions, please type or let me know if there's anything else you needed. How does pregnancy affect? Oh, that is a fantastic question. Andrea, I don't know the answer to that from like a weight base, because there'd be a higher weight. I think I don't treat gestational diabetes, so Endo does that, but I'm happy. I will take down your name and look into that question for you, because I do not see any pregnancy in my clinic, so I will pick on that one. What other questions are there? For pregnancy, the recommendation is, oh, I didn't think that was a question in terms of type 2 diabetes and medications. I thought it was, how does pregnancy affect the basal maximum dose that we were talking with weight-based dosing? But Andrea, please tell me if that was your question in terms of what are the recommendations in pregnancy? Because Sarah is definitely correct that insulin is it. Okay, thank you, Andrea. What other questions? How can I help? Oh, here we go. Can you explain the max? Yeah, of course. So just to walk through, and I might actually, give me 1 second, because when I'm teaching this to the med students, I created visual, so maybe this will kind of be helpful as I talk through it. So give me 1 second. All right, I'm going to share my screen again. So hopefully you see this now. So if we think under the concept of total daily dose, and generally for type 2 diabetes, we say 0.5 to 1 unit per kilo per day being max. And so in most cases with type 2 diabetes, we'd like to have a balanced regimen. So 50% basal, 50% prandial. And so if you're under that total daily dose of 1 unit per kilo per day, and we want a 50-50, if you divide it in half, that's your basal max. So then a quick way of doing this in practice is when you're looking at your patient, if you know their weight in kilos and cut that in half, that is essentially their basal max. Now, could it be that they are 100 kilos and their basal max is 50 and their A1C is 7.4 and you just need a little bit more tweak to get them down, so you're going to increase to 55 or something? Absolutely. But if you get 20% and on up above that basal dose, I think you're missing the fact that they need the postprandial control, which that basal insulin is not going to offer them. So Tiffany, let me know if this helps. Good. Fantastic. Let's stop sharing again. What else? One thing I thought we might do is walk through some of the resources on our webpage, and I thought just to make sure, since I think there's a lot of great stuff here. So under resources and medications, hopefully you've seen we have various coverage guides. If we scroll down here, the dosing chart, that's both for GLPs and SGLT2s. And while this one is done in a beautiful way with the help of our designers, we tried to put as much information that you might need to make a decision between agents. I think the other thing that we didn't really talk about when deciding between the various agents of the classes of SGLT2 and GLPs is cost. And so, I find that with my Medicare patients, I have to do a lot of work to get these medications covered for them at an affordable price. And so I tried to help design the background of this to help you make some informed decisions and have a conversation with your patient. And so one of the things we don't always do, but that I've become, when I have patients that are in the Medicare category, I let them know when you get to the pharmacy, if the copay is hundreds of dollars or even $75 or $100 and you're not used to that, tell the pharmacist to keep the medication and send me a portal message or call the office to ask to speak to me. And then we'll see if you could qualify for something else. And so I think knowing about these patient assistance programs is something that is a great service that we can do to our patients. Now, I will say there's restrictions, and we tried to, yes, I am sharing. Sorry, I want to make sure you can see what I'm doing. Understanding the income boundaries, if you will, and when you have that patient portal message you, if you have this sheet accessible at my clinic, I just put together binders. And so all the resources that are on our webpage, I have in those little leaflets so that each team, I have 4 different teams within my clinic, can have access to this, because I recognize I think if we're not in a virtual situation, we can't be pulling up all of these things on the web. That doesn't work with our clinic flow. But if they've come back to the staff room and they're sending some orders, they can have this on paper and kind of ask patients where they fall. The one thing I would like to point out with the SGLT2s is I've made my frustrations known when I've met with some medical MSLs and medical liaisons that say for Jardiance, which is typically is my go-to if I have one, that they include assets in patients' income. So if patients have retirement, they're not going to qualify. So I had this happen to a patient. They were seen by nephrology. Nephrology started empagliflozin. I saw the order come through and I was like, oh no, she's not going to be able to afford this. I had her on NPH insulin that she got at Walmart for $25 because she couldn't afford anything. So sure enough, within a few days, I was getting a phone call. Patient wanted to talk to me. And I eventually got her on Farxiga through their program, because if you see with Invokana, the cost, she has to spend 4% of her gross income on prescription drugs. So I think these little nuances help me. I had a discussion with nephrology saying, you know, she's doing okay on her NPH. They really wanted her on it for the nephrology protection. And so I explained that to patient and said, let's see if we can get this for you for an affordable cost. And she's doing all right. We'll probably have to wait a year to see if we really get that renal benefit out of it. But this is just one of the ways I kind of navigate some of these situations. So hopefully that was helpful. What else? How can I help? I'll keep checking chat. Is there anything you'd like to see in future presentations that I give that I didn't come with today that you were hoping to get? Please share ideas, questions. Otherwise, I can certainly end early and let you have 15 minutes of your lunch back to yourselves. You can answer portal messages and emails. If things come up after this and you think of something, please reach out to us and let us know your questions for these types of meetings that I'm going to hold monthly. If there's something more I can provide or have ready for you or look into, I'm happy to do so. Oh, you're welcome. Tiffany, do you know of any injectable GLPs that come with needles? Oh, yeah, so that's a great question. And that actually came up at our meeting on Friday. So thank you for asking that question. So I'm going to go back. Give me 1 second to my slide. So if you if you look at the second row here, pen type, and then we come below it and it says pen needle prescription required. So these two, I hope none of us are really using Byetta anymore, because I don't know why we'd be making our patients inject themselves twice. So really the only one truly you have to worry about pen needles with is liraglutide or Victoza. Semaglutide or Ozempic technically comes with 6 needles per pen. Now, in some instances, I have prescribed Ozempic in some of my patients that I know travel a lot or have things mysteriously go missing in their house. I might prescribe pen needles. To your question, in those cases, when they're too expensive, say you prescribed Victoza, and I think on Friday, we heard that the copay was $50. Again, I try not to steer patients to certain places, but Walmart with their cheap NPH, they also have really cheap Rely-On needles, and they're $6 a box. So I think that's something you can use as an alternative. For the semaglutide patients, let's say you wanted to give them a little bit more, you can always prescribe a pack of 10 pen needles that are far cheaper than the box of 100. So that would be, most useful for the semaglutide patients. All right, what else we got here? So hopefully it helps, Tiffany. If not, let me, oh yes, it was okay. So Lisa, patients who need a complete overhaul of their insulin regimen, I love this question. Where do you start? For example, a patient taking bolus insulin in PR, they're an example of taking bolus insulin and PRN basal. Okay, well, I think one of the things would be is I would go back to my general approach. So if I was referred this patient for the first time, I'd get an understanding of diet. I'd get an understanding of blood sugars. And from there, I'd probably inquire at the first visit, how did you come about being on this regimen, and try to get the history that I can't get out of the chart. I read the charts in depth. I think I still always ask patients about what other meds they've been on, because that'll cue me in on sometimes how they've gotten to where they are. But in this case, I think I'd probably talking through diet, if there was anything I could focus on from a lifestyle perspective. And then I think the other piece of information that's missing here is what their A1C is. So if their A1C is near goal and they're practicing this way, it's probably going to be a harder sell, but I'd still try. If their A1C is uncontrolled, then, getting daily blood sugars, fasting specifically, because I think if you could, I'd have to figure out what would the prandial, Lisa, can you either type or unmute in terms of, were they taking scheduled bolus with each meal? Was it sliding scale? Was it fixed dose? Can you share anything more, or is this just a general question? Yes, scheduled sliding. So I think then educating patient of how the insulins work together, that basal insulin is basal. And typically, this patient is type 2, I assume. So I just spent some time understanding how they got on this, but I want to eventually reverse it. I think one of the things you could do is, if they're not checking fasting, get a fasting, and then he designed his own. So then getting some fasting and maybe getting a 2-hour, 3-hour postprandial after his largest meal, And if that happened to be dinner, then you could have like a fasting and bedtime blood sugar and just talking through it. I find when I spend the time with my patients and I talk through the fact that, you know, especially if his postprandial might be less than 180, 160, and then he's waking up high all the time because he has zero basal control, that's where you can then illustrate to your patient why they need basal insulin, and talk through that process. So I generally, that would be my approach, is to, on that first visit, not tear it down and try to earn the patient's trust by focusing on some lifestyle things that I might be able to build that rapport with, and then start to dial in on you know, seeing if they're willing to hear my perspective in my area of expertise, and working through the data that they are sharing with me to how we might benefit and make his control better. So that would be how I would approach it. Let me know if you have further questions. I think it's tough. I think, oh, he also had a brain injury. Okay. So yeah, I think in that case, I think I really try, when I say patient-centered, I really, really pride myself on, I think too, I see this in the learners I have with me. They say, why do you spend so much time talking about all this other stuff when just like prescribe them a drug? And I put in the time to understand that foundation, understand where the patient's coming from, be patient-centered, because I can tell you, in the patients that I might spend 1 or 2 visits with doing that, and I'm not making a ton of changes, at the end of the day, when I get to gain their trust, they listen. But I think if I come in there with the, you know, I have my PharmD, you know, this is what I want to do. It's their life. And so I just really try to take that approach. And if again, it takes me a few visits, even a couple of months to do that, it's a chronic disease. So I'm not going to cure this thing, but I need to get them believing what I'm saying, trusting me, and starting to work together. And I think that's how I base my practice. And I've been quite successful with my patients by practicing evidence-based, but most importantly, patient-centered. And the other thing I will say to all of you is I have the luxury of time. I don't have a ton of time because I get my hand slapped if I spend more than a half an hour with patients now, because it's all about seeing a quota of patients per day. But I think I certainly get more than my docs get on like a quick return visit in 20 minutes. So I try to utilize that, and certainly my access might be 6 weeks out, but it's not 3, 4, 6 months out like the docs that I work with. So I do acknowledge that I have that luxury. Got 6 minutes to go. Anything else I can answer, help with? All right. Well, I thank you all for joining me today. I hope you found this beneficial. Please reach out to us if there's specific things you would like me to go over at our next one. If you just want to have open forum or some like non HPI case-based discussion, I'm always happy to do that. I think my own docs have asked how we can incorporate that into my day. So I hope you all have a wonderful day, a wonderful 4th of July. So take care.
Thank you so much, Heidi.
Thank you, Jackie.